You know that feeling, that sudden sharp pain maybe in your side. Or perhaps it's more of a dull ache that just lingers after you eat.
Yeah, we've all had those moments. And, well, sometimes it's nothing serious, just your digestion acting up a bit.
Right, but other times,
Yeah,
it can be a sign that something deeper is going on, some kind of inflammation inside.
exactly. And when we're talking about that kind of trouble in the digestive system, the gallbladder and the bile ducts, they're often right in the middle of it.
Which brings us to today's deep dive. We're focusing on cholecystitis, that's gallbladder inflammation, and choledochitis, inflammation of the big bile duct.
That's the plan. We've looked at some really good source material on these conditions.
Yeah, we have. And our mission today is really to sort of unpack them. What are they exactly? What causes them? How do doctors figure them out? And importantly, what can be done?
Think of it as getting some practical knowledge about a pretty vital, if small, part of how your body works.
Okay, let's jump in. Cholecystitis and choledochitis. Can you break those down for us? What's happening physically?
Sure. So cholecystitis, in simple terms, is when the gallbladder itself gets inflamed. You know, that little organ tucked under the liver. It stores bile.
Right, the stuff that helps break down fats.
Precisely. Then you have choledochitis. That's inflammation in the large bile duct, the pipeline carrying bile from the liver and gallbladder down to the intestine.
Got it. And reading through our notes, it seems these conditions rarely just appear out of nowhere. They're often related issues, right?
That's a really key point. They're often linked. Gallstones cholelithiasis is the technical term, are probably the most common association. Very frequent.
Okay, gallstones. What else?
We also often see gallbladder mucosal, GBM. That's when the gallbladder gets filled with this really thick, almost mucus-like bile, sludgy,
What a clog.
kind of, yeah. And then there's EHBDO, that stands for extrahepatic bile duct obstruction. Basically, a blockage in that main bile duct outside the liver.
So blockages are a major theme.
Definitely. Along with just general inflammation in the biliary system, the network of ducts, it's all interconnected.
It sounds like a plumbing problem almost. A blockage somewhere causing trouble downstream. And it seems like this can get pretty serious.
It absolutely can. If the gallbladder gets severely inflamed, it can actually rupture.
Rupture. Wow.
Yeah. And that leads to something called bile peritonitis, bile leaking into the abdomen. That's a surgical emergency, usually requiring medical support too.
Okay, that's serious. And what about the bile duct blockage, the EHBDO?
Well, if that main duct gets blocked, it really ups the risk of a bacterial infection spreading.
How does that happen? Bacteria getting into the bile ducts.
Uh-huh. So your intestines normally have lots of bacteria, right? If bile flow stops or slows way down because of a blockage, these bacteria can, they call it translocate, meaning they can basically move across the gut wall, get into the bloodstream, and travel up into the liver and the whole biliary system, the gallbladder, the ducts.
And that causes infection.
Yes. It can trigger a significant bacterial infection, releasing toxins. It can even lead to sepsis, where the body's response to the infection becomes dangerous itself, or septic peritonitis if that infected bile leaks out. It's a cascade effect.
That really does paint a serious picture. So
Yeah.
who tends to get these conditions? Are certain groups more at risk?
Well, the sources say both dogs and cats can get cholecystitis and choledochitis. There isn't a strong link to specific breeds or sex, but it does seem that necrotizing cholecystitis, a really severe type where the tissue starts to die, is seen more often in middle-aged to older dogs.
Okay. And you mentioned gallbladder mucosal, GBM, earlier. Our notes highlighted a specific link there with dogs that have high fat levels in their blood, hyperlipidemia.
Right, yeah. That's a fascinating connection. Dogs with high blood lipids, which can happen because of other issues like Cushing's disease, hypothyroidism, diabetes, pancreatitis.
The underlying health problems.
Often, yes. Or even things like using steroids, certain kidney diseases, or just an inherited tendency in some breeds. Think Shetland sheepdogs, miniature schnauzers.
And how does the high fat lead to the mucosal?
Well, the idea is that the excess fat changes the bile composition, makes it thicker, sludgier. This thick bile builds up, causing cholestasis, poor bile flow, and that can then trigger the inflammation, the cholecystitis.
Ah, okay, that pathway makes sense. So if this process starts happening, what are the warning signs? How would you know if it's cholecystitis or choledochitis?
It can differ a bit. With choledochitis, the main bile duct inflammation, the signs can be kind of vague, maybe come and go. Jaundice is often a key thing. You might notice that yellowing of the skin or eyes.
And for cholecystitis, the gallbladder inflammation or the GBM?
That can often be more sudden. You might see, loss of appetite, being really lethargic, vomiting, maybe some general abdominal pain, perhaps worse after eating.
So post-meal discomfort could be a clue.
It could, yeah. Mild or moderate jaundice can show up too, maybe a fever. Sometimes it's just this chronic low-level discomfort after meals.
And what about very severe cases?
In really bad situations, shock can develop. That's from the bacterial toxins and dehydration. And sometimes, in smaller animals, a vet might actually feel a sort of mass in the upper abdomen where the inflamed gallbladder is.
Okay, so a range of signs, from vague discomfort to sudden severe illness. Let's talk about the root causes. What actually triggers this inflammation?
It can be several things. Anything that messes with bile flow, really, a blockage, like we said, maybe at the gallbladder's exit or within the gallbladder itself.
What else?
Problems with the gallbladder's movement dysmotility, they call it, if it doesn't contract properly.
Right.
Or even reduced blood supply to the gallbladder wall.
So physical issues, flow issues, anything else?
Yeah, irritants in the bile itself, especially if it's sludgy. Things like lysolecithin, prostaglandins. The gallstones themselves, obviously. Even liver flukes in some areas.
Parasites, wow.
And in cats, sometimes digestive enzymes from the pancreas can backflow into the bile duct and cause irritation. Also, previous gut problems, abdominal trauma, even surgery can sometimes be factors. Rarely there are birth defects like colodocal cysts.
It sounds like infection's a pretty common player in all this, too.
Oh, definitely. Bacterial infection is very common. It can happen either by bacteria traveling up from the intestine, that's retrograde invasion, or spreading through the bloodstream.
And are there specific bacteria usually involved?
In those really severe necrotizing cases, especially with rupture and gallstones, E. coli and Enterococcus species are found pretty often. There are rare causes too, like certain parasites, but bacteria are the big ones.
We also saw a mention of emphysematous cholecystitis. What's that about? Sounds unusual.
Slight pause. Yeah, it is less common, thankfully. Emphysematous means there's gas involved.
Gas inside the gallbladder.
Right. Or the bile ducts. It's associated with things like diabetes or trauma that cuts off blood supply or just really bad acute cholecystitis. Certain bacteria like Clostridia or E. coli can actually produce gas.
Okay, that adds another layer of complication. So if a vet suspects cholecystitis or choledochitis, how do they actually confirm it? What's the diagnostic journey?
Well, first they need to consider other possibilities because the symptoms can overlap with lots of things.
Like what?
Oh, pancreatitis, other kinds of peritonitis, simple gastroenteritis, gallstones without major inflammation, inflammation involving the liver too, cholangiohepatitis, liver damage or abscesses, other causes of bile duct blockage, GBM without severe inflammation, even sepsis from another source. So ruling things out is step one.
And then I assume tests come into play. Blood work, urine tests.
Exactly. Lab tests are crucial. You often see changes in the white blood cell count, suggesting infection or inflammation. Bilirubin levels are usually up. That's what causes the jaundice, and you might see it in the urine too.
What about liver enzymes?
Those are typically elevated ALT, AST, ALP, GGT, indicating stress or damage to the liver and biliary system. If there's peritonitis, protein levels like albumin might drop. And with bile duct obstruction, cholesterol and bilirubin can climb.
And with the mucous cell connection, maybe high lipids too.
Yes, you might see hypercholesterolemia or hyperlipidemia in those cases as well.
Are there more direct ways to test, like sampling fluids?
Absolutely. If there's fluid in the abdomen, taking a sample abdominocentesis can show inflammation, and finding bile confirms bile peritonitis. Getting a bile sample itself for culture is really helpful.
How do they get that?
Often during surgery, or sometimes carefully with a needle guided by ultrasound. Culturing it tells you exactly which bacteria are there, if any, and what antibiotics will work best.
Okay. Any other tests?
Yeah, sometimes blood clotting tests might be abnormal, especially if bile duct obstruction has been going on a while because it affects vitamin K absorption. Or in very severe sepsis, you might see signs of DIC, a serious clotting disorder.
Then there's imaging. That must be vital for actually seeing the problem.
Hugely important. Imaging is key. X-rays might give some clues. Maybe things look hazy in the abdomen if there's fluid or the intestines aren't moving well. Sometimes you can see dense gallstones or gas, or rarely a calcified gallbladder wall.
But ultrasound sounds like the main tool here.
Oh, absolutely. Ultrasound is incredibly informative. It can show fluid around the gallbladder, thickening of its wall. Sometimes specific patterns in that thickening can even suggest the severe necrotizing form.
What else can it show?
There's a double rim look to the wall, sometimes seen with various liver or bile duct issues. The kiwi sign is pretty specific for gallbladder mucosal. The inside literally looks like a kiwi fruit slice.
Wow.
Yeah. Ultrasound can also pick up signs of rupture, a visible defect in the wall, or fluid around it, or just widespread fluid in the abdomen. Sometimes you can't even find the gallbladder if it's ruptured or missing. It can show mineralization, dilated bile ducts inside the liver if there's ascending infection or obstruction, and that fluid around the gallbladder we mentioned.
It's specifically for choledochitis, the bile duct inflammation.
It might show a thickened common bile duct wall, maybe debris inside the duct, sometimes extending up into the smaller ducts within the liver. It gives a really detailed picture.
So putting it all together, imaging, labs, symptoms, what about what's actually seen if surgery happens or during pathology?
Well, visually, the gallbladder might look really red, angry, or even greenish-black if tissue has died. With a mucocele, it's full of that thick, tenacious material. You might see gallstones, sometimes blood. The common bile duct wall might look thickened and contain debris or pus.
Okay, so we've got a diagnosis. How do you treat these conditions? What's the approach?
Treatment often means a hospital stay, especially for critical cases or if sepsis is suspected. Stabilizing the patient is the first priority. IV fluids are essential, keeping a close eye on electrolytes.
What about supportive care?
Plasma might be needed if protein is low or there are clotting issues. Blood products like packed red cells or fresh frozen plasma might be necessary if surgery is planned and there's bleeding risk. Usually, artificial colloids, certain types of fluids, are avoided in septic patients. And monitoring urine output is critical.
Any specific concerns during procedures?
Yeah, vets need to be aware of the vasovagal reflex. Manipulating the biliary tract can sometimes cause a sudden drop in heart rate and blood pressure, so they need to be ready for that.
And surgery? Is it usually required?
For cholecystitis, removing the gallbladder, a cholecystectomy is often recommended. The final call is usually made during the surgery itself based on how things look.
What about medications? What's in the toolkit?
Antibiotics are key. Usually started broad spectrum, covering gut bacteria, especially before any surgery. Then they're tailored based on those bile culture results we talked about.
Any specific ones?
A common initial combo might involve something like metronidazole plus, say, ticarcillin clavulinate or maybe a fluoroquinolone. The dose of metronidazole might need adjusting if there's significant jaundice.
Okay, antibiotics, anything else?
Ursodeoxycholic acid is important. It helps thin the bile and improve flow. You give it by mouth with food, but crucially only after any major bile duct obstruction is fixed.
Makes sense. Don't want to push bile against a closed door.
Exactly. Antioxidants like vitamin E or SAMe might also be used to support the liver cells. SAMe needs to be given on an empty stomach, usually with an enteric coating.
And vitamin K.
Yes, vitamin K1 is often given early, especially before surgery, to help with clotting. Important note, it should only be given by injection under the skin or into muscle, not into a vein, because of potential reactions.
Are there times when these meds shouldn't be used? You mentioned ursodeoxycholic acid and obstruction.
Right, that's the main one. Ursodeoxycholic acid is contraindicated, meaning shouldn't be used if there's an uncorrected extrahepatic bile duct obstruction or if there's active bile peritonitis.
Got it. So after treatment starts, what does recovery look like? How is progress monitored?
Monitoring is really important. Regular checkups, repeating blood tests, and maybe imaging every, say, 2 to 4 weeks until things normalize. If sepsis was involved, antibiotics are usually continued until liver enzymes are back to normal.
Any potential bumps in the road during recovery?
Well, if there was a rupture of the biliary tract or significant peritonitis, the clinical course can sometimes be quite prolonged and challenging. It takes time to heal from that kind of insult.
Okay, so let's try and summarize the key takeaways here. Cholecystitis, choledochitis, inflammations of the gallbladder, and bile ducts, often linked to things like gallstones, obstructions, mucocele.
Yeah, and recognizing the signs, which can range from vague discomfort to sudden severe illness, is crucial. Diagnosis involves piecing together history, exam findings, lab tests, and especially imaging like ultrasound.
And treatment. It often requires hospitalization, supportive care, antibiotics, maybe specific meds like ursodeoxycholic acid, and frequently surgery to remove the gallbladder.
That covers the essentials.
So thinking about this, for you listening, It really brings home how interconnected everything is inside, doesn't it? How an issue in a small organ like the gallbladder can ripple outwards and cause significant problems.
Absolutely. It's a reminder of the body's complex balance. Maybe it encourages you to think a bit more about your own digestive system, that intricate machinery, and pay attention to those subtle signals it might send. It's fascinating stuff when you really dig into how it all works together.